to our Diabetes Awareness Month webinar here at HPSM. For those who are who've joined our webinars in the past here with our provider services and health education teams, this is part of a new series that we're launching this year, really to help do a couple of things. One is to really celebrate the rich and diverse community that we live in here in San Mateo County. And then second, in our role here as the health plan and the payer for our Medi-Cal population in San Mateo County, we want to really use that kind of bird's eye view that we have as a payer to share what we're learning around health disparities, and then really connect you with great resources here in our community for our providers who are helping us to close those gaps and are really caring for our patients here in the community. So if we can go ahead and jump to the next slide here, I want to do a couple of introductions of who you're going to be hearing from today. That is myself. I'm Colleen Murphy. I'm our Network and Strategy Officer. We're also joined by Sarah Munoz, our Health Promotion Supervisor, and Joe Solowaychuk. Joe, did I pronounce your name correctly? Great, great. Who we are very excited to have joining us today as our guest speaker. Joe is the leader of A Mile in My Shoes Consulting, and really a wonderful advocate and an expert on diabetes care that we work with here at the Health Plan of San Mateo. So that's who you're going to be hearing from. I'm going to do a real quick, if we can jump to our next slide here. A real quick introduction. So we want to know who we are joined by today. We are using Teams, so I'm not sure if everyone is familiar with that, but there is, if you look at the top, a little button that looks like a cartoon bubble that should open the chat window for you. And if you want to go ahead and jump into the chat and just type out your name and organization for where you're joining us from. And would love to hear from folks if you could share a little bit about why you joined our session today. We're also going to do a live poll here. So before we start, we want to do a bit of a kind of pre and post check on how well we are providing information today. So our first question for you, which we'll drop here into a forms poll, is to really just get a feel for kind of how confident you feel today serving patients with diabetes or with pre-diabetes diagnoses today, kind of going into our conversation. So you should see a little poll that just dropped there into the chat. You should be able to click on one of those buttons and then hit submit, and we can see where our audience is at. Great. Great. And I think we have a couple of folks just joining us who've logged in the last moment. So just a real quick note to those who've just joined. We are just getting started with some introductions for folks who are on the line. We are recording today's session, so you'll note that button is there at the top, and welcome. Great. All right. So I do see a couple of familiar faces here in our audience. So just wanted to pause for a moment and just ask for a quick hello from folks. I do see Rami. Nice to see your face here. It's a face that I know, and I know you're joining us from Anara. Would love to ask for folks to say a couple words about your organization and what you're hoping to get out of today's session. Oh, and Rami, I think you might be on mute.
There we go. I always do that. My name is Rami. I am an internal medicine physician here in San Mateo. And at Anara Health, which is the medical group I work with, we specialize in obesity, have a pre-diabetes program and a diabetes program. So we sort of focus on those core areas. And I'm just here to get to know more of the HPSM community, as well as the different efforts around the community with regards to both diabetes and pre-diabetes.
Great. Thanks, Rami, and welcome.
Oh, thank you.
And just looking at our list of attendees, if you don't mind me calling on you, I'm going to call on Colleen. Fantastic first name. But Colleen Lem, if you are on the line, would love to just say hello to folks and just let us know where you're joining from. And Colleen, we might have you on mute. Well, I am seeing that we have a fair number of folks on the line today, so we won't run through everyone's introductions. If you do feel so inspired, please do drop a note in the chat to just let us know where you're joining us from so that we can have some conversation with you as we jump into our Q&A portion of today's discussion. So if we can jump to our next slide here, we have now about 50 minutes together, and really kind of within those 50 minutes we want to accomplish a couple of things. Just to kind of reorient to why we're here, as I shared at the beginning, really trying to focus on celebrating the kind of diverse and rich community that we're in. Really, again, use that role as a payer to share data that we have, kind of that unique perspective that we have as a payer on what we're seeing around health disparities in our community. And to provide real concrete resources that folks can use. So again, we'll be talking a little bit today about both HPSM and community resources to help serve folks with a diabetes or prediabetes diagnosis, and really hope that you can take some of those away from the conversation today. And our next one here, our hope for this next kind of 50 minutes or so together is to really increase your knowledge about Diabetes Awareness Month, to come away with some specific resources that you might be able to actually use today, and then also to hear directly from Joe about some best practices for really treating patients with diabetes or prediabetes. So with that, we can jump over to our definition of really who we are talking about today.
Thanks, Colleen. So hi, everyone. My name is Sarah Munoz. As Colleen mentioned, I am the Health Promotion Supervisor. And today we'll be focusing on 3 primary groups through this presentation. So those at risk of developing diabetes at some point, for example, members with prediabetes, those who have type 1 and type 2 diabetes, and those with gestational diabetes. Next slide, please. As part of HPSM's annual population needs assessment, we look at HPSM's Medi-Cal population demographics and disease prevalence. Based on 2020 data, we see that diabetes is one of the top most frequently diagnosed conditions amongst our membership. We also see that the majority of members with diabetes as their top most frequently diagnosed condition were 51 to 64 years old and had an English language preference. Next slide, please. As part of HPSM's annual population needs assessment, we also look at gestational diabetes within HPSM's Medi-Cal population. In 2020, 13.6% of all pregnant Medi-Cal members were diagnosed with gestational diabetes, compared to 12.8% in 2019. Members who identify as Asian or Pacific Islander continue to have the highest rates of gestational diabetes at 25%, up from a rate of 7.1 in 2019. And the overall rate for all HPSM members is 15.6% compared to the California gestational diabetes rate of 9.5%. Next slide, please. HPSM's population needs assessment also includes an assessment of our quality metrics or HEDIS measures to identify any potential disparities. This slide shows the 2020 disparity analysis findings of the diabetes-related HEDIS measures. All findings shown are at a statistically significant level. We see that members with Tagalog language preference have the highest rates of HbA1c testing. Members who are 65 to 74 have high rates of HbA1c testing and low rates of HbA1c port control. Members with Chinese and Vietnamese language preference have the lowest rates of HbA1c port control. We also see some disparities. Members who are 12 to 50 have low rates of HbA1c testing and high rates of HbA1c port control. And members who identify as male have low rates of HbA1c testing. Next slide, please. And now I will pass it on to Joe.
Thank you. Hello, everybody. Just a brief introduction. My name is Joe Solowychek. I'm a diabetes nurse and a family therapist. And my specialty is linking how families communicate and how patients communicate with their family members and with each other. And and how that impacts metabolic control. I've also been working as a diabetes nurse and family therapist and educating patients, working with patients, inpatient, outpatient, for I would say about 40 years. And the way I got into working with diabetes and why I have such a passion for it is that I also happen to have type 1 diabetes myself. This year will be 60 years. And I can tell you this, if we're trying to find out why most people don't want to take care of diabetes, it's probably because it's a pain in the neck. And it gets boring after the first 2 weeks. I think the first 2 weeks when you get the blood sugar meter and you get your this and you get your that, there's sort of an excitement and I'm going to get this doing. But then slowly after the first 2 weeks, what sort of seeps in is the realization that this is not just a one-shot deal. So let's talk a little bit about, so that's my background, and open for any questions or concerns or issues that you want to talk about in the chat room, or perhaps if we have some time later and sort of question and answer. But just a sort of brief thing, I don't want to bore you with too many statistics. Most of what we'll be talking about today will be more conversational, and I'll use the slides to sort of jump off into things that I wanted to share with you that I think are critical to working with patients and their families with diabetes. And I do say families, meaning that the families need to be included. But just in general, in California, from the California Department of Public Health brief from 2016, medical expenditures to treat diabetes, $1.9 billion a year. And in the state of California, an additional $800 million is lost in productivity related to work. 2,693 million per year related to end-stage renal disease, $195 million a year related to amputations and loss of limbs. What's sad about this, and what's I think most practitioners already know, so I'm sort of preaching to the converted, is that we have a cure for type 2. We know that all of these complications, or most of them, can be prevented. That it is a treatable disease, and it is the better care you take of yourself, the less chance you have of developing complications. So lifestyle modification, eating, meal planning, right medication, and exercise. That's all it takes. And I say that sarcastically and tongue-in-cheek because that is a lot. The cure is there, but it's how to help patients get to that sort of realization or that sense of engagement that they want to take the plunge. So next slide, please. I'll just talk to you a little bit about my own experience in living with diabetes. This was my insulin delivery traveling kit. As you can see, the end of the needle, it was a glass syringe, U40 insulin. Had to give the shot in at an angle, otherwise you would be at risk for hitting the muscle. This was a Becton and Dickinson travel kit. I still have it to this day, and it's my only souvenir and sort of reminder, besides the fact that there's not one day in the last 50 so years that I've woken up and said, yippee, I can't wait to take care of my diabetes. The thing that I think most people have a problem with is that it's like having another full-time job. The only problem is that you don't get paid to do it. It's connected and on top of everything else that you have to do. And if you would ask me what the most difficult part of living with diabetes is, just from a personal perspective, I would say it's all the work. It's exhausting. Sometimes it's scary, sometimes it's frightening, sometimes it's frustrating. You do the best that you can do, and it's not good enough. And the numbers, it's a humbling disease as well, in terms of putting in so much effort, and your body will do what it will do. And there are things that are out of your control. And I think if we're talking about working with patients and really correcting healthcare disparities and pushing for more engagement, I think we have to recognize that it is exhausting and that it does take a lot of work. And that my favorite prayer for, in addition to helping patients learn how to adjust their insulin dose, I'm a big, big advocate of training patients to manage most of the disease by themselves. Most people, it doesn't really take a lot of rocket science to manage diabetes. I hate to say it, it just does take a lot of courage and determination on a daily basis. The prayer that I'm referring to, that I hand out to patients that I work with, in addition to the information that I'm giving them about how to manage it, is the serenity prayer. God grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. I can tell you, when I wake up in the morning and my blood sugar is 200, 250, and I know that I had a bigger ice cream the night before, that's on me. But there are mornings when I wake up and my blood sugar is 250, 252, 253, something like that. And I think to myself, what did I do? Dream of pizza? You know what I mean? There are things that occur in the course of managing diabetes that just are absolutely frustrating and infuriating if you're a person who likes to take charge of what they're doing. And I'm one of those people. And so this is a sort of balance over the course of my lifetime, and I think our patients' lifetimes, of balancing, checking in, suiting up and showing up, as well as taking breaks every so often. And this kind of balance between total engagement, pulling back a little bit, falling off the wagon, getting back on the wagon. We need to help patients sort of understand that it's not a one-shot deal, that it's an ongoing struggle, and that we're in knee deep with them, and that this is not something that they have to do by themselves. Next slide, please. So in terms of cost reduction and improvement of quality of life, what patients need really is they need access to care, and they need access to quality and comprehensive care. What does that exactly include? Next slide, please. So treatment goals, ABCs, A1C, blood pressure, cholesterol. Here are some of the, I won't read the slide for you. I know you can all read. I'll just tell you that these are the things that we need to emphasize. Plus, in addition to that, we need to do foot checks early on, and we need to make them a part of the regular protocol when screening or seeing patients in our offices. Next screen, please. So what are some of the components of what patients need to get there? Well, one would be diabetes self-management tools. And here are some guidelines and some resources that are available for patients with type 1 and type 2 that I use a lot, and that are available online, or you can get printouts for free from the CDC, the American Diabetes Association, all of these sort of from the American Association of Diabetes Care and Education Specialists. Core 7 diabetes self-management curriculum is critical. If you're having issues about how or what the content should be of your diabetes education in the context of your office or your practice, the Core 7 diabetes self-management curriculum of the American Association of Diabetes Care and Education Specialists is absolutely incredible. It has everything that you need to be addressing as a clinician when working with patients. What it doesn't say so much is how to go about doing that. It gives you the content of what to do, and I'd like to talk a little bit about how to go about doing that. Next, please. Oh, and I'm sorry, for the, go back, sorry. For the competent and ongoing psychosocial assessments, the most reliable that I use in my practice and recommend that others use in their practice is there's a high association between depression and diabetes. And in type 2 diabetes, it's not quite sure, you know, if it's the chicken or the egg, diabetes first and then we get depressed, or depression and experiencing severe depression and then as a result of that trauma, moving into type 2 diabetes. But regardless, when patients come into our offices, we need to make sure that we're doing some kind of assessment that's part of the initial visit protocol. And for every 6 months or every year at least, to make sure that we're staying on top of that. PHQ-2 or PHQ-9 are great assessment tools. Those are available online, and you can just put them in. They're easy to answer. You put them in where the patient comes in and they're writing all their sort of details about address changes or this or that or whatever whatever you use as an assessment tool for when the patient comes to your office from the reception. You can look at this in your office, and they associated with the assessment scale tool is also online a scoring for where people are. And the other thing about competent and ongoing psychosocial assessments is that practitioners I really believe that we need to have resources in place. It's not enough to just tell somebody that they're depressed, but we have to have some kind of plan in place to help them deal with that depression. The best treatment for diabetes and depression depression that might be getting in the way of diabetes management or management things that are being confounded by depression is cognitive behavioral therapy plus medication. Those two things. One without the other is not as effective, but the two approaches that seem to be most effective for helping patients with diabetes manage their disease more effectively by overcoming some of the obstacles that are presented to them with depression, meaning I don't feel like I can do it, this is overwhelming, not being able to exercise, eating as a result, emotional eating or not eating, all of these things are very effectively dealt with medication, the right medication. So we need to have referrals for patients, or at least a sense of competence and skill in prescribing the right medication, psychiatric medication for patients, antidepressant, plus some kind of program for talk therapy. That could be by a nurse educator who's trained in that, which I am, or it could be someone that you refer out to. Thanks. And then competent ongoing case management. I see my role as a diabetes nurse educator, and I see our roles as providers of care for people with diabetes as having to stay on top of the situation. It's not I'll see you in 6 months and then, let's pick up from where we left off. There should be more engagement, more high touch. If you're thinking about, whether you should push for more high touch over high tech, I would say yes. The more high touch, studies have shown, meaning calls. I send flowers to my patients from time to time, just congratulating them on staying in the game, that kind of thing. The more things you can come up with creatively that work also financially, flowers can get expensive, I would say do it. Because managing diabetes by yourself is a lonely prospect. And to know that you have a team behind you, lots of times can help patients get over those sort of hurdles or the obstacles that seem to get in the way. I'm doing this all by myself. I'm exhausted. I can't do this anymore. It's frustrating. No matter what I do, it's not changing. What we have to do is provide the education. Next slide, please. Diabetes self-management education in terms of what constitutes what I consider an adequate and competent sort of diabetes self-management education curriculum, pathophysiology and rationale for treatment, blood sugar lowering medications and their use, orals, insulin, and injectables. It's amazing to me how many times I meet patients that come from other clinics and other places where nobody's ever explained to them the pathophysiology. What has been explained to them or what was given to them was, here's a blood sugar meter, or here's a prescription for a blood sugar meter. Here's the medicine. Take 2 of these and I'll see you in 6 months, or I'll see you in 3 months. So pathophysiology, rationale for treatment, blood sugar lowering medications and their use, and how they work, and the pharmacokinetics involved in this. Adjusting medications based on blood sugar patterns. I'm a very big advocate of teaching patients how to adjust their own insulin doses, and if appropriate, and the physician-patient relationship is comfortable enough and close enough, oral medications as well, based on based on patterns of blood sugars. Meal planning. Somebody needs to sit down with the patient, every patient, and probably every family member around all of this stuff, but particularly around meal planning. Carb counting and how to plan for weight loss, how to reduce obesity, how to integrate meal planning into exercise. There are 1,001 sort of possible combinations of how we talk about meal planning, and it's important to put in there as just as a given after the first visit with the diagnosis, or with someone who's been diagnosed for a while but hasn't gotten this stuff. This is the core of what they need to be able to, at least for us to be able to say as providers, that we've given them the tools. Whether or not they use the tools is another story. We'll talk about that in a minute. But at least we have to feel confident that we've been able to give them the tools that they need. We need to go over signs and causes, symptoms, and treatment of hypo and hyperglycemia. And we also need to talk to them about sick day rules and prepping for surgery and when to call us and when to make changes. And if they have any questions, we need to be accessible. That's the other piece. And that is hard for a lot of us in terms of our busy schedules and questions that come up. But I can tell you, the more accessible you are, I have not done a study about this, but I would imagine, I would bet that the more accessible you are, the better the A1C will be, at least from our end to their side, you know. Okay, cool. Next slide, please. Ongoing depression and psychosocial screening and assessment. We talked about that a little bit in terms of PHQ-9, PHQ-2 diagnosis, assessment, and screening and treatment. I forgot to put that in as well. So, and aggressive and proactive case management. I would say the most important thing in diabetes is not to treat to next appointment, but to treat to target. So if that means making an appointment in a week, even if it's by phone, and these days it's so easy to use, and we're getting reimbursed for telehealth medicine, and Skype or Zoom or however you work it out of your office, a brief conversation with the patient about what's going on in terms of your blood sugars. Has the metformin that I prescribed for you done anything for you in the last 2 weeks? Have you noticed a change in your fasting? Have you noticed a change in your post-meal blood sugars? As a way of testing whether or not a patient is serious around wanting to really get on this stuff, I tell them that they need to do at least 6 blood sugars a day if they don't have CGM. But if they don't have CGM, I'm asking them to do 6 blood sugars a day just for a week so that they get an idea about what their diabetes looks like. It's way more easy for a patient to sort of not do what they're supposed to do if they're not engaged in the data that's involved in the management and in the care. But if we say, let's say I make a deal with you, you give me a week of diabetes boot camp, I say to the patient, and I will give you what your diabetes looks like and the tools that you need to move forward in terms of managing it aggressively to prevent complications. If you give me a before and 2 hour after, before and 2 hour after, before and 2 hour after of every meal throughout the day, we can really tailor your diabetes management to get to where you need to get to in terms of reaching those target goals that I talked about before. Patients need to have access to the most effective drugs. They need to know what drugs are available. If it were, you know, like I said, it doesn't take rocket science to manage diabetes, but it does take knowing what's out there. I can help patients if there are no CGM, there's no blood sugar checking. I could help patients manage their diabetes based on urine sugars if needed to, you know. And I can teach them how to use regular insulin and MPH insulin if they need to. But they need to be talked to about it and talked with about it, and to get their ideas about what's going on from them about the impact of diagnosis. What's it like for you to have diabetes? What is the most difficult thing that you have to deal with on a daily basis living with diabetes? These questions are important. I know they slow down your sort of encounter time, but I think at least one visit every 3 months or 4 months or 5 months should be designated to and dedicated to finding those things out. What's it like managing this thing? How do you feel when you have to come in here and you know your A1C is high? I congratulate you for still coming in. What is it that I can help you with? What we have to do is stop thinking that it's all our responsibility to lecture and work, and we have to think about ways to get the patients to assume responsibility. Assess access to specialist care, nephrologists, ophthalmologists, podiatrists. Patients that we see really need to be referred out to those people that, to those specialists when the need arises. Next slide, please. What it takes for patients to get there. So this is the hard part, because we all know what to teach patients, but what's the sort of secret about having a conversation? Teaching them or telling them what to do is different than having a conversation about what they think they can do. And we'll get to that in a few minutes in terms of motivational interviewing. But what it takes for patients to get there is knowledge, courage, determination, a measure of self-discipline. I won't fool you, it's required. There's no way to do this without some sense of that. And the motivation. Knowledge is not enough. How many of us at one point in our lives used to smoke and knew while we were smoking that it was dangerous for our health? Knowledge does not necessarily lead to more doing. Motivation usually leads to more doing, which then leads to more knowledge and in starting that feedback loop. Next slide, please. So what it takes for providers to help patients get there, I think, is compassion, sensitivity, having genuine dialogues and conversations, not lectures, trained team in diabetes self-management education, someone who's available to do that stuff, prescribing the right medications for each patient, not just one size fits all, capacity to provide ongoing case management, treat to target, not to next appointment. Treatment assessment, treatment assessment, treatment assessment. This is an ongoing thing. The illness is chronic. The assessment and the high touch points need to be as chronic as the illness. That's my sort of philosophy about working with patients with diabetes. And it doesn't matter which kind of diabetes, type 1, type 2, gestational diabetes, and across the spectrum of whatever kind of diabetes you have. These are the things that we need to be able to provide patients with when we tell them that they have diabetes. Next slide, please. What it takes for providers to help patients get there is oral medications, insulin, injectables other than insulin, motivational interviewing, appropriate psychiatric psychological referral, and emotional and psychological support. The picture that you see on there is this guy told his parents that he felt different because he was wearing an insulin pump. Now, I'm not suggesting that all of us as providers need to go and get a tattoo of a pump on our abdomens, but I'm just saying that this quality of support is what I'm talking about. Different than just saying, hey, nice job, or this kind of thing. Really getting in there, three-dimensionally, compassionately, sensitively about what can we do to help you? A call every so often, a letter every so often, just saying we're in touch, we're available if you need us, we're here for you, that kind of thing. Next slide, please. Okay, motivational interviewing. Motivational interviewing, the goals of this thing, I think, really is just be nice. Be nice with the people who you're working with. Treat your patients as if they were your mother. Well, maybe not that, but as your family, you know. What we're going for is to generate internal discussion for the patient. No lectures, but our goal is to help the patient have a discussion about their priorities. The other goal is to roll with the resistance, or a technique is to roll with the resistance. Lectures are the best way to get resistance. But a conversation, like I was suggesting, which is, how do you feel about being diagnosed with diabetes? What's going through your head at this moment? What is the most difficult part for you? Why do you find it difficult Why do you find blood sugar checking more difficult than this or this? Whatever opportunity you can have to let the patient talk more and encourage conversation, what will end up happening is that, as per motivational interviewing, as we understand what motivational interviewing is and does, patients will leave your office with that discussion going on. If we get that, we are successful. There's an opportunity here to sort of drop. We want to push for the goals, but we don't want to push too much because it's very easy for us to push more than the patient wants to push. So rolling with the resistance, encouraging conversation, dialogue, that kind of stuff, asking more questions as opposed to lecturing. These are sort of the core concepts of motivational interviewing. Next slide, please. Involve the patient as an active participant in the relationship with you. Learn brief negotiation strategies for use in healthcare settings. Clinician creates opportunities for the people to explore change based on careful listening and empathy. What we would like is for the change to come from within. The way to get within is to have a conversation, not a lecture. Next slide, please. It's important to also note that different people are at different places about being ready to change. This is the Bukashka stages of change model that's used very frequently together with motivational interviewing. People in pre-contemplation are not really interested in getting going. You might just want to continue the relationship with them and have a conversation. You'll ask them, what are you thinking about in terms of, it's not for me, maybe we'll talk about this at the next session or something like that. They're not even thinking about it. People who are in contemplation are now starting to consider that they might be interested in taking care of themselves or getting engaged in the disease management process. The next stage would be preparation. They have taken some concrete steps to prepare for getting into action, and then getting into action and then maintenance. Out of all the stages, I think getting from pre-contemplation to contemplation is the hardest, and going from action to maintenance is the hardest. But if you'll notice the way the sort of rings go here, there's movement up and there's movement back. This is not a static, linear kind of a drive. You go from doing nothing to doing everything. You'll move back and forth across this spectrum of stages, depending on where you are in life. You might be going through a very difficult time about job or economics, finances, or domestic issues that are occurring that are making it difficult. Managing diabetes, like I said, doesn't require a lot of rocket science, but it does require a lot of focus and dedication to doing it. And if there are other things going on in life, it's going to be, you're going to have that much less energy economically to devote to managing your diabetes. I know when I am going through a mild depression or a tremendous life stage change, I'll usually resort to a Snicker bar as a way of sort of dealing with some of my emotions. Let's help patients work through those stages and not sort of judge them as a backslide, but that if they're sliding back, it meant that they had made progress. Maybe this is just one stage in the road of back and forth and up and down and around. Why my patient, next slide. Just questions that you ask yourself, what my patient ambivalent? This is what patients could be ambivalent about. And this is where we want to focus in motivational interviewing for getting patients to be addressing their ambivalence. Acknowledging their ambivalence is the first step in change. So, ambivalent, I have diabetes, I don't have diabetes. I'm obese, I'm not, I'm dealing with hypertension or not hypertension, hyperlipidemia, medications, inactive lifestyle, diet, glucose monitoring, keeping records, keeping appointments, changes at home. What is there not to be ambivalent about in terms of taking on the chore of managing this thing on a daily basis and managing it from soup to nuts? Maybe the goal is to say, you know what, I can do this 80% of the time. I can't do it 100% of the time, 100% of the time. I can't do it 100% of the time. The only way you'll get to know where patients are interested in making those changes, and if they bring to you their best guess at where they think they might be, you're much more likely to reach a goal than if we tell them this is where you have to get to. I think we need to provide for them the sort of overall arching targets that are set by CDC, ADA, ACE, all that kind of stuff. But at the end of the day, patients will do what they will do. And we want to get in there with them in this process of moving from one stage to another. Next slide, please. What tips the balance towards change when using motivational interviewing? Collaboration, as we talked about, partnership. We're consultants. This is a service industry. We're a negotiator for change. We want to help manage that conversation and direct the conversation to be the most self-efficacious for the patient, evoking discussion, listening more than telling, elicit rather than install information, taking reflection breaks. I heard you say that. This anchors thoughts and positions of the patient in the context of our conversation and relationship with them. Reflecting back what I thought I heard you say is a way to let the patient know that you're listening and that it's important. Expressing empathy. Oh, if I had diabetes, I don't think I would be able to even show up at the doctor's office. You know, there's just too much. Something like that. Or I don't know exactly what it's like, but from all the things that you're talking about what present as difficulties, that sounds like a lot. And then respect, honor the patient's autonomy, emphasizes capacity rather than incapacity. You ask permission. Can we talk about meal planning? Would it be okay if we talked about meal planning for a second? And as opposed to assuming that patients want to hear about that. One way to start would be, what is it? I have some thoughts about what you need to know in order to manage your diabetes, but I'm more interested in hearing from you what you think is important and where you'd like to start. I can work with you on this. This is healthcare negotiator, asking permission, listening, eliciting conversation, and then rolling with the resistance, not getting bowled over or not making things so rigid by getting a patient to sort of resist from the get-go. One of the ways to roll with resistance is to just ask permission. It's a very easy thing. Can we talk about? Would it be okay if we talked about this kind of stuff? Cool. Anyway, next. This is the MI importance ruler. If you don't use anything else in your practice in terms of motivational interviewing or sort of having an in-depth conversation, the importance ruler says, how important would you say it is for you to check your blood sugar on a scale from 0 to 10? 0 is not important, 10 is extremely important. Where would you say you are? And then what you can do is, using these numbers, you can say, why are you at a 6 and not a 9? I thought you would have said a 9 or a 0 or 5 and not 0. Meaning, why are you at a 5 and not a 0? Is emphasizing capacity as opposed to incapacity. And what would it take for you to go from a 5 to a 7? This is engaging the patient on drawing on their inner resources to provide the treatment plan that, in other circumstances of just telling them what to do, you'll have to tell them again and again and again until they get tired of hearing about it. And then the next really important tool is the confidence ruler. How confident are you that you could check your blood sugar on a scale from 0 to 10, where 0 is not and 10 is extreme? Where would you put yourself? They say, okay, a 5. Why are you at a 5 and not a 0? They will be able to then share with you why they think they're at a 5 and not a 0. What would it take for you to go from a 5 to a 10 or a 9? This opens it up for the patient to ask us to help them achieve their goal. This is the goal of motivational interviewing. Next, please. What you want to do is really listen for commitment. So what do you make of all this now? What do you think you'll do? What, if anything, do you plan to do? What do you intend to do? What we want to do in these conversations is be clear that we anchor and reinforce and support whatever we hear the patient saying that they're interested in doing in order to move from one stage, maybe pre-contemplation to contemplation or contemplation to action. We want to reinforce this and anchor it again in the conversation. It's okay to say ask the same question 2 or 3 times and to re-emphasize these things 2 or 3 times. You're not you're repeating it, but with the idea of anchoring it in the core of the conversation that the patient is having with himself and his disease. Next, please. What tips the balance against change? We went through all these guys, but the most important one, I think, that really tips the balance against change is you working harder than the patient. If you want this patient to take better care of themselves than they do, then you got a problem. And I tell the patients, I say, listen, I'm happy to work with you, but I will not work harder than you at this. I have to take care of my own diabetes. I want you to get the best care, but you'll need to show me that you're interested in doing it, and I will lean a shoulder to that effort and get in the trenches with you. Next, please. Here's some resources in terms of motivational interviewing. These guys, Miller and Rolnick, are the sort of gurus of motivational interviewing. There are no shortage of resources online for motivational interviewing. If you're not interested in taking a course or not able to take a course in healthcare coaching and getting a certificate in healthcare counseling or something like that, motivational interviewing is your best place to go. In terms of getting ideas about how to change the nature of the core relationship between you and your patients. And then A Mile in My Shoes Consulting, which is my own private practice, working with healthcare professionals and patients living with diabetes. I have a private practice here in the Bay Area. I also do telemedicine, telehealth stuff. I work with via Zoom or FaceTime or whatever sort of ways patients are interested in working in. Or if you had a patient that you wanted some professional consultation with in terms of which direction to go, I am available to do that. And the next slide, please. So maintaining motivation and not only reaching targets, but staying at targets. This, I think, is mastery level. How do you stay once you got there? It's easy for a lot of people to get to where they need to get to, but staying there is the definition of chronic. Chronic motivation, chronic engagement for a chronic illness. And we have a large part in how that unfolds. Even if patients don't really want to get on the engagement bandwagon, I still think it's important to be nice with them, non-lecturing, welcome them into the office. A lot of times patients will come back to me and they're not doing anything for months. And say, listen, I just got to ask you something. What is it that you wanted me? What kind of help could I offer you? Because it seems like, for the most part, everything that we talk about, you're not doing. I use sarcasm because it's part of my New York sort of state of mind. Whatever you are in terms of natural clinical approach, I said, I'm happy to work with you, but if you don't want to do diabetes, let's just talk about sports. And we'll talk about diet and I'll bill at the lowest level or something like that. The maintaining motivation is really the most difficult part of diabetes management. And that happens in the space between the patient and the provider, where patients feel like they're cared for, cared about, that their stories and difficulties are being heard, and that there's a genuine desire to work together as opposed to, I'm going to tell you what to do. Next, please. So that would be it from my side. I will hand it back to you, Sarah.
Thanks, Joe. So now I will be discussing the programs that HPSM has in place to prevent diabetes amongst our members. First, we have our Diabetes Prevention Program, which is a 12-month program that aims to prevent or delay the onset of type 2 diabetes among individuals diagnosed with prediabetes. Members who enroll learn how to make healthy lifestyle changes like eating healthy and getting more exercise. Members must meet the following to enroll into this program. They must be 18 years or older, not be pregnant, have no previous diabetes or end-stage renal disease diagnosis, and they must meet one of the following. Within the last 12 months, they must have a blood test result in the prediabetes range. This can be an A1C test, fasting plasma glucose test, or a 2-hour plasma glucose test, or they must have a previous gestational diabetes diagnosis. Members can be referred through our health education line at 650-616-2165, or providers can visit our website at the link provided to access the referral form. We also have our Baby and Me program, which connects members to community resources such as WIC. The program also incentivizes members for going to their prenatal and postpartum appointments with a $50 Target gift card for each visit made within the specified timeframes. This helps encourage members to get care early during the prenatal and postpartum period, which includes getting tested or treated for gestational diabetes on time. To enroll, members must be pregnant or must have recently had a baby. Members can be referred through our health education line, or providers can visit our website at the link provided. Next slide, please. As Joe mentioned earlier in the presentation, diabetes self-management tools are very important for managing diabetes. HPSM has a diabetes management program in place to support members in managing their diabetes. The program includes communications such as health tips on the health education guide available through HPSM's website. The link is provided on this slide. Member and provider newsletter articles that include tips and resources for managing diabetes. For example, earlier this month, we mailed out a diabetes-focused newsletter to members with diabetes. The cover of the newsletter is shown on the right side of this slide. As part of HPSM's diabetes management program, we also provide internal staff with talking points and protocols for connecting members to community resources and programs. Through HPSM's health education line, we connect members to community resources and programs for managing diabetes. One of the main programs that we connect members to is the San Mateo Medical Center Diabetes Self-Management Program. We would also like to hear from you. If you or your clinic have diabetes self-management programs or education opportunities available, please enter those in the chat or email them to us after the presentation, and we'll contact you to learn more about your program. Next slide, please. Other resources available for our members include behavioral health resources. For non-emergency mental health or substance abuse treatment referrals, members can be connected to the BHRS call center at 1-800-686-0101. Other support resources can also be found on our website at the link provided. Lastly, there is also opportunity to improve self-efficacy in diabetes education using empathy and emotional support in diabetes care. A patient's learning ability can be significantly impaired if the patient experiences emotions and stress caused by negative feelings around diabetes. Working to calm down the patient and address their concerns first will improve learning ability when teaching any diabetes management skills or knowledge. For example, when injecting insulin or monitoring blood sugar levels. Next slide, please. And now I will pass it on to Colleen.
Great. Thanks so much, Sarah, and thanks all. We are running a little bit short on time this afternoon, so lots of good stuff to cover, but we do have just a couple of minutes left and did want to open up the floor for questions for the group. Additionally, we did want to just check in and see kind of, how helpful today's session was. And so we're going to do one more round of Teams survey that we will pop here into the chat. You'll see that pop up on your screen, and just checking in with folks to see how you're feeling in terms of level of preparedness and confidence in serving patients with diabetes or pre-diabetes after today's session. I'm also seeing a couple of notes here, and I just wanted to thank both Bobby and Colleen for saying hello and letting us know where you were joining us from. But with that, I will pause for a minute and just see if anybody has any questions for our speaker or for the HPSM team.